Good evening, friends. Today we shall learn about very important topic, that is anesthesia for one lung ventilation. So preoperative assessment of the patient. In the preoperative assessment of the patient, this is very important, that is a three-legged stool of prethoracotomy respiratory assessment. Because we have got many battery of pulmonary function tests ranging from spirometry, that is static lung function test, dynamic lung function test, we have got flow volume loops, we have got ABG, we have got DLCO. So in so many tests are there. So of all these tests, the most important for the anesthesiologist are this the FEV1 and the DLCO. So these should be the predicted postoperative values should be more than 40%. Okay. So in this respiratory mechanics, what we have to assess is that is FEV1 and maximum voluntary ventilation, forced vital capacity. Now coming to this lung parenchymal function. Lung parenchymal function is assessed by seeing this DLCO, that is diffusion capacity of the lung for carbon monoxide. The post-operative predicted value should be more than 40%. How this calculation is done, it will be discussed in the next slides. And the PaO2 should be more than 60 and PCO2 less than 45. And in addition to these two, the cardiopulmonary reserve also has to be assessed. So this can be assessed by using this gold standard test, that is cardiopulmonary exercise testing, or by doing stair climbing test, and also by 6-minute walk test. During the 6-minute walk test, the fall in saturation, it should be less than 4%, and the patient should be able to climb more than 2 flights of stairs during this stair climb test. So this is all the preoperative, whatever this criteria which are required for the patient to undergo pneumonectomy, lobectomy and segmentectomy. So I will be all this table is given in 6th edition Miller, so you can go through to it, and this is I will only highlight the important ones. So the FEV1, FEV1 is important because it determines how the patient can cough or not. Because if the FEV1 is less, if it is post-operative predictive value is less than 40%, or if it is less than 1 to 1 liter, then what happens? Patient will be unable to cough effectively, so that leads to retention of airway secretions and lung collapse can occur. So that is why this FEV1 is important. And this predicted FEV1. Post-operative predicted FEV1 minimum should be post-operative predicted should be minimum should be 0.8 liters for almost like pneumonectomy, lobectomy and segmentectomy. For all the cases it is the same. Now coming to this exercise testing. Exercise testing for pneumonectomy, patient should be able to climb 5 flights of stairs, and for lobectomy 3, and for segmentectomy 2 flights of stairs. And here this VO2 max, that is maximum oxygen consumption, normally it is in a sedentary adult, it is 40 to 50 ml per kg per minute. In a patient who has to undergo pneumonectomy, it should be more than 20 ml per kg per minute, and lobectomy and segmentectomy, it should be more than 15 to 20 ml per kg per minute. So now we shall know how to calculate this predicted post-operative FEV1. So for this we should know this, that is the lung is divided into subsegments. In right lung we have got 22 subsegments, and in the left lung we have got 20 subsegments. So for example, take in this patient, if right lower lobectomy is done, so then 12 subsegments will be removed. So what will be the predicted post-operative FEV1 is equal to preoperative FEV1 of the patient into 1 minus the number of segments which are going to be removed divided by total subsegments. So that comes to around, if the preoperative FEV1 is 3 liters into 1 minus 12 by 42 is 30 by 42, that comes to 2.14 liters, which is very well above the required value. So this patient can undergo right lower lobectomy. Now coming to, when this FEV1 and DLCO are less than 40%. So when it is less than 40%, it is a high risk, and cardiopulmonary exercise testing is mandatory in those patients. If it is DLCO and FEV1 is more than 60%, then it's a low risk for lung resection, and between 40 to 60% it's a moderate risk for lung resection. Now coming to diffusing capacity for carbon monoxide. It is a very simple and non-invasive test. It is most useful for measuring gas exchange capacity of the lung. In the similar way, as we calculate this predicted postoperative FEV1, in the similar way only, the predicted postoperative diffusing capacity for carbon monoxide is also calculated. That is equal to preoperative DLCO into 1 minus subsegments to be removed divided by total subsegments. Now this ventilation perfusion scan. When we have to do ventilation perfusion scan in a patient, whenever the preoperative FEV1 and the DLCO are less than 80% in a patient who is posted for pneumonectomy, this ventilation perfusion scan has to be done so that we can know what amount of perfusion and what amount of ventilation is going to the diseased lung. Now coming to cardiopulmonary exercise testing. This is cardiopulmonary exercise testing. It is a gold standard test to assess the cardiopulmonary interaction. Because it is a very time-taking test and it is also expensive, there are many surrogates for the cardiopulmonary exercise testing that include 6-minute walk test and stair climb test. In detail, this discussion is done in my previous presentation, that is preoperative assessment of the patient. So here, whenever this VO2 max is less than 10 ml per kg per minute, then it indicates very high risk, unacceptably high risk, and that patient should not undergo thoracotomy. When it is 10 to 20 ml per kg per minute, moderate risk of perioperative morbidity and mortality is there. And when the VO2 max is less than 20 ml, is more than 20 ml per kg per minute, then it is low risk. What is this VO2 max? That is maximum oxygen consumption. How do we calculate this VO2 max? This VO2 max, it is calculated in cardiopulmonary exercise testing according to this machine derived calculations will be there, and in case of 6-minute walk test, a very simple calculation is there. In the 6-minute walk test, the distance walked by the patient in 6 minutes divided by 30, this value it gives the VO2 max. For example, patient walks around 600 meters in 6 minutes. 600 divided by 30, that is equal to 20. So 20 ml per kg per minute will be the VO2 max in the patient. Now coming to preoperative respiratory care regimen. So preoperatively respiratory disease patient, they will be having cough with expectoration, and they will be having copious amounts of sputum secretion in patients with bronchiectasis. They will be smoking, or they may be exposed to industrial pollutants, and they may be having thick mucus plugs, and few patients will be having bronchospasm. And because of this copious amount of secretions, the patients will become, there is loss of protein, and patients will become malnourished, and patient will be anemic also. And so there is a preoperative respiratory care is required for all these patients. So first and foremost, what we have to do is the patient has to stop smoking and avoid industrial pollutants whenever applicable. And second thing is we have to dilate the airways. That is, we have to give the bronchodilators to the patient, and then we have to loosen secretions by improving the hydration status of the patient and also by using mucolytic drugs. And once all these mucolytic drugs are given and this hydration is improved, now we have to remove the secretions by giving expectorants or by doing chest physiotherapy and also postural drainage. And we have to give antibiotics for infection, and we have to also improve the nutritional status of the patient. And in addition to all this, we have to encourage preoperative incentive spirometry and also preoperative respiratory exercises to these patients. And also we have to stabilize other medical conditions, like patient may be having ischemic heart disease or hypertension or diabetes mellitus. All these conditions will be there. Now coming to final preoperative assessment. So in the final preoperative assessment, what we have to do is, one thing is we have to review the reports. Okay. Then we have to see for if there is any difficulty we can anticipate for insertion of the double lumen tube. So assess for difficult endobronchial intubation. So we can do a chest X-ray and we can see the CT scan also if there is any abnormal anatomy of the tracheal bronchial tree, so that whether this endobronchial intubation is easy or difficult, we have to assess. And also we have to assess what are the risk factors for desaturation during one lung ventilation. So the risk factors are increased risk factors are right-sided thoracotomy, and also when there is high percentage of ventilation or perfusion to the operated lung on preoperative VQ scan. In this X-ray, we can see this is the trachea and there is an abnormal anatomy of the tracheobronchial tree. So this patient will be facing the difficulty in endobronchial intubation. So this is why this preoperative chest X-ray will be very useful. So now going to the physiological aspects. Coming to this physiology, the normal physiology is that 55% of the cardiac output it goes to the right lung, and the 45% of the cardiac output goes to the left lung. Whether this is in upright position, that is either in patient is in upright position or in supine position. Now, whenever the patient takes this lateral decubitus position, then there is 10% increase in perfusion to the dependent lung. For example, when patient takes the right lateral position, then right lung receives 65% of the cardiac output and left lung gets 35%. When the patient takes left lateral position, then the left lung gets 45 plus 10, that is 55% of cardiac output, and right lung gets 45% of the cardiac output. Now coming to the physiology of how this ventilation and perfusion will go in a patient, in an awake patient. In an awake patient, see here we can see in an upright position. In an upright position in awake patient, the apex of the lungs, here the alveoli are already distended or alveoli are already expanded. So they will not be having much to expand. So and they will be on the plateau phase of this compliance curve, and the base of the lungs here the alveoli are small and they are along the steep phase of this compliance curve, so they expand better. This means in case of awake and upright patient, ventilation is better in the dependent areas of the lung. And always remember that whichever the position of the patient, whether it is upright position or supine position or lateral position, always perfusion is more to the dependent areas of the lung. So in an awake patient, so perfusion is better in the dependent areas of the lung, and also the ventilation is better in the dependent area of the lung. So this is how the ventilation and perfusion are matched in an awake patient in upright position. So for example, now take this patient who assumes this lateral decubitus position. When this lateral decubitus position, right lateral decubitus position is there, here perfusion will be more to the dependent lung. And now we shall see how this ventilation will be, because this the dependent area of the lung, here the alveoli will be small and they will be on the steeper phase of this compliance curve, so they are better ventilated. And one more thing is, because here the diaphragm is pushed up by the abdominal contents, because the diaphragm is actively contracting, and that is why that is also one of the reason why ventilation is better in the dependent lung when compared to the non-dependent lung in an awake patient in lateral decubitus position. Now coming to lateral decubitus position in an awake versus anesthetized patient. So here as I told previously, in an awake patient, ventilation is better in the dependent lung and also perfusion is better in the dependent lung. That is how this ventilation and also perfusion are matched. When the patient is anesthetized, what happens? The active contraction of the diaphragm is decreased. So then now what happens? The ventilation will be better in the non-dependent lung. But however, a perfusion will remain same, that is it is better in the dependent lung. So perfusion is better in the dependent lung and ventilation is better in the non-dependent lung. So here that is why there is a VQ mismatch in an anesthetized patient in lateral position. Now coming to lateral decubitous position and chest is open and patient is breathing spontaneously. What will happen? What will be the physiology we shall see? See here the chest is open, the patient has assumed this lateral position. Here what is happening, whenever this chest is open, that becomes an open pneumothorax. Because there is no negative intrathoracic pressure here, what happens, this lung, it tends to collapse. And also this mediastinum, there is no negative intrathoracic pressure to hold this mediastinum in the midline. That is also the reason this mediastinal, it falls on the dependent lung. So this is called as mediastinal shift occurs here. So this is called as mediastinal shift. And because of this mediastinal shift, the ventilation of the dependent lung is also impaired. And same in lateral decubitous open chest and spontaneous ventilation. Now we shall see what happens during inspiration. During inspiration, what happens is the air from the non-dependent lung, it enters the dependent lung, and also some amount of air it enters from the atmospheric to the dependent lung also. And during expiration, what happens, from this dependent lung air, it will go to the non-dependent lung, and part of the air it goes to the atmosphere. So here this occurs because of the loss of the negative intrathoracic pressure. So here what is happening in case of spontaneous ventilation, open chest and lateral decubitous position, the air is moving from one lung to other lung. So this is called as air pendulum, okay, or paradoxical respiration. So because of this, there is a gross ventilation imbalance in the patient, and that is why they develop desaturation. And all that is why always controlled ventilation is advised whenever thoracotomy is done. Now coming to plan of anesthesia. What is our plan of anesthesia in thoracotomy patient? Our plan of anesthesia is definitely general anesthesia with controlled ventilation. And now coming to pre-medication. In pre-medication, if the patient is having, we should avoid this anticholinergics because they dry up the secretions and making suctioning difficult. So that is why usually glycopyrrolate is avoided. And in patients who are having increased pulmonary artery pressure or increased right ventricular systolic pressure, that is more than 35 millimeter of mercury or pulmonary hypertension, in those patients we have to avoid sedative premedication, because giving the sedative premedication, it can cause hypoxia and hypercarbia, leading to further increase in pulmonary artery pressure. And now coming to epidural catheter. Epidural catheter is usually placed in the preoperative room or during the pre-induction time. Induction agents. In induction agents, thiopentone is usually avoided as it is prone to cause bronchospasm. Propofol is a very good drug, so it produces bronchodilation. It can be used. Now coming to after giving this induction agent, now we have to isolate the lung. How to isolate the lung? There are various methods of isolation of lung. One is the double lumen tube. Second is we can do this, use this Univent tube. It is a single lumen tube with built-in chamber for advancement of integrated blocker. And then is we have got endobronchial blockers are there, and also we have got single lumen tube. Single lumen tube, it is advanced into the bronchus using fiber optic bronchoscope. Now we shall see what are the different types of double lumen tubes. Basically, all double lumen tubes they are more or less a modification of the Carlin's tube. So the Carlin's tube, it was first introduced, and it is a left side and it has got a carenal hook. And White's double lumen tube, it is a right sided tube. It also has a carenal hook. Later, all these are modifications of Carlin's tube. That is Robertshaw double lumen tube, Malincrot bronchocath double lumen tube, Bryce-Smith and Salt, Vivasite and Sheridan-Sherwin broncho double lumen tube. In this Vivasite double lumen tube, it has got an inbuilt camera at the bronchial end, so that we can visualize it is going in which bronchus the tube is going. See here, this is the Carlin's double lumen tube. Carlin's, it is a left-sided double lumen tube and it has got a carinal hook. This carinal hook, it sits here. So the disadvantage of this Carlin's tube is because passage is difficult at the level of the vocal cords, because this carinal hook, it can cause trauma to the vocal cords. That is why in this Robertshaw tube and also Mallinckrodt bronchocat double lumen tube, this carinal hook was removed. Now coming to Robertshaw double lumen tube. In Robertshaw double lumen tube, this is nothing but two tubes which are bonded together, and it is available. Previously it was available as red rubber tubes. Nowadays it is available as PVC tubes. It has got two lumens, that is, one is the tracheal lumen, another is the bronchial lumen. The tracheal lumen, it is white and bronchial lumen is blue, and even the pilot balloons are also color coded, that is blue color for bronchial and white color for tracheal. Okay, and here this is the tracheal cuff, this is the bronchial cuff, and these are the connectors which we use to attach to this double lumen tube. So I will be doing a separate video on how to insertion of the Robertshaw double lumen tube. So as I told previously, these are two tubes which are bonded together, and it is available in sizes 26 French to 41 French, and the shape of the lumen, it is D-shaped in Robertshaw double lumen tube. And coming to size, so these are the, in case of adult female less than 160 centimeters, we have to go for 35, and more than 160 centimeters is 37 size we have to use. In males either 39 or 41. So these are all given according to the Western literature, but in our practical experience what we have seen is 35 in usually in case of females, and also 37 or 39 in case of males. So here we can see what is the size of the single lumen tube and the corresponding size of the double lumen tube. So the single lumen tube's internal diameter of 8 corresponds to the 32 French double lumen tube. Okay, so we may have to use 32 or 35 double lumen tube in case of females, and in case of males usually it is 37. Now coming to what is the difference between, we have got both right-sided and left-sided double lumen tubes. So what is the difference between this right-sided and left-sided double lumen tube? So the main difference is related to the cuff. So the right side DLT, it has got a modified cuff. So there is a slot for ventilation of the right upper lobe. In case of left side DLT, it is not there, and that is why, because it has got a modified cuff and also proper positioning is required. So the insertion is difficult, and also the fiber optic bronchoscope is mandatory for proper positioning of right sided DLT. Compared to this, left-sided DLT insertion is easy. And one more thing, the angle of bronchial portion is 20 degrees in right-sided DLT and 40 degrees in left-side DLT. So here you can see in this diagram. So this is the right-sided double lumen tube. Here this is the modified cuff is there. So that this right upper lobe bronchus can be ventilated here. In case of left-sided double lumen tube, here there is nothing like that. There is no modification of the bronchial cuff. So here we can see the anatomy of the tracheobronchial tree. The anatomy of the tracheobronchial tree, here this right bronchus. From this right bronchus, from within this 22 millimeter, that is 2.2 centimeters, there is a branching of the right upper lobe bronchus. So that is why here when we insert the double lumen tube, we have to position it appropriately so that right upper lobe is also getting ventilated. But in case of left bronchus, after 5 centimeters there is division of the bronchus. So there is a margin of safety is more in case of left-sided double lumen tube. Now usually whether it is a right-sided surgery or a left-sided surgery, usually we prefer left-sided double lumen tube only. The reason is, as I told previously, because of the ease of insertion. Whether it is right-sided surgery or left-sided surgery, we use a left-sided double lumen tube because the ease of insertion, that is left side is easier to insert, and also the margin of safety is more. So in which patients we have to go for right-sided double lumen tube? In patients who are posted for left-sided pneumonectomy and also who are having abnormal anatomy of the left mainstem bronchus is there, and compression of left mainstem bronchus due to descending thoracic aneurysm, and also left-sided sleeve resection is being done and left lung transplantation is done. So in all these conditions, basically it is usually commonly what we encounter is left-sided pneumonectomy, and in case of sleeve resection. Now coming to insertion of double lumen tube. I will be doing a separate video on insertion of double lumen tube. So here this double lumen tube, it has got two curvatures. One is the distal curvature and another is the proximal curvature. So these two curvatures are at 90 degrees to each other. So by facing this distal curvature towards the roof, initially we have to pass the double lumen tube with, after introducing the stellate. Always we have to use the stellate for insertion of double lumen tube. So when as soon as it passes beyond the level of the vocal cords, then we have to turn the double lumen tube towards our left if it is a left-sided double lumen tube, towards the right if it is a right-sided double lumen tube, and pass until we feel this resistance. After we feel the resistance, then we have to remove the stellate. You first inflate the tracheal cuff and then later inflate the bronchial cuff. Bronchial cuff, it should not be inflated more than 1 to 3 ml of air. Now coming to what are the advantages of Robertshaw double lumen tube. So Robertshaw double lumen tube advantages are it allows independent ventilation of each lung separately, and also suctioning and fiber optic bronchoscopy is also easier. And even the resistance which is offered by the tube is also less when compared to previous older tubes. What are the disadvantages? Disadvantage is intubation is difficult when compared with single lumen tube, and also at the end of surgery if we have to go for elective mechanical ventilation, then we have to remove the tube and we have to introduce a single lumen tube, and also here stellate is mandatory, and airway damage during placement is also there. This is how the position of the double lumen tube should be. So in this diagram, A diagram, the fiber optic bronchoscopy is inserted through the tracheal lumen. After inserting through the tracheal lumen, here we can see this is the carina, this is the right bronchus, and this is the left bronchus. Here what is happening, we are not able to see the bronchial cuff. That means this left-sided DLT, it is advanced too much inside. This is the right placement of the left-sided double lumen tube. So here we can see that this is the carina, and we can see the cuff of the bronchial cuff is barely visible. This is the appropriate position of the DLT. Now coming to endobronchial blockers. Sometimes because of difficult intubation or whenever the anatomy is different, then we have to go for endobronchial blockers. That is, we have to use a single lumen tube and pass an endobronchial blocker. So the different types of endobronchial blockers are Arndt blocker, Cohen tip, flexitip blocker, Fuji blocker, and EZ blocker. This is the Univent single lumen tube and bronchial blocker. Here we can see this is the single lumen tube, and it has got an attached integrated bronchial blocker. So this integrated bronchial blocker, here you can see here there is a cuff, and it has got a separate pilot balloon, and it has got an internal lumen also, so that through this we can do suction, endobronchial suction can be done. This is the Cohen flexitip endobronchial blocker. Here we can see this Cohen flexitip endobronchial blocker. It is attached and inserted through the single lumen tube. using an adapter. And here this, it has got a pilot balloon, we can inflate this one, and this circular this thing is there. Here with the help of this one we can do this movement of the tip of the bronchial blocker. So that is why it is called as flexitip endobronchial blocker. And also through this attachment we can pass fiber optic bronchoscope, and under guidance of fiber optic bronchoscope we can position the endobronchial blocker appropriately. This is the EZ blocker. In this EZ blocker, here we can see we have got two blockers. That is, one is for the right and another is for the left. So here in this one, what is the advantage is whenever patient has both sides surgery has to be done, then we can pass this one at the and put it at the level of carina, and we can inflate the left side and ventilate the right side. And if we want to ventilate the left side, then we can inflate the right sided cuff and inflate the left sided. So alternately we can change this ventilation between right side and left side without any change of the endotracheal tube. If it is a double lumen tube, we may have to change again, remove it and again pass a right side double lumen tube. But in case of when we use an EZ blocker, so we can alternate this right and left lung ventilation without change of ET tube. So that is the advantage. Now coming to pediatric lung isolation technique. As we have seen previous slide, that is the smallest size available double lumen tube is 26 French. So in case of pediatric, how the lung isolation is done? This single lumen tube, it can be passed endobronchially, and that is we have to pass endobronchially under the fiber optic bronchoscope guidance, and also there are balloon tipped bronchial blockers. And even Univent tubes, smaller size Univent tubes are available, that is 3.5 and 4.5 mm internal diameter Univent tubes are available. And in case of adolescent patients, we can go for double lumen tubes. That is smaller size double lumen tubes, that is 26 or 28. This is the Mararo's bilumen pediatric endotracheal tube. Here we can see this is the advanced into the bronchus, and this is for the trachea. Now coming to monitoring. What monitoring we usually do in patient who is posted for thoracic surgery? Or these are heart rate, ECG, SpO2, EtCO2, airway pressure monitoring I have to do, that is peak airway pressure, plateau pressure, invasive blood pressure monitoring, CVP, temperature, urine output, arterial blood gas analysis also is done. Now what are the ventilation parameters we keep during one lung ventilation? So here we have to maintain two lung ventilation till the pleura is opened, and once the pleura is opened, one lung ventilation is started. How this one lung ventilation is started? So as soon as the pleura is open, we have to clamp the bronchial or the tracheal as appropriate, and we have to ventilate through the other lumen. So now what we have to do, either pressure control ventilation or volume control ventilation. If we keep volume control ventilation, tidal volume should be less than 6 ml per kg, and this plateau pressure, it should be less than 25 centimeters of water, and peak airway pressure should be less than 35 centimeters of water, and we have to adjust the respiratory rate to maintain normal PCO2. And in few patients, permissive hypercapnia is also allowed with pH of more than 7.25. IA ratio is kept as 1:2. FiO2 100% oxygen we have to give to this patient, because during this one lung ventilation, what happens, as I told previously, that is 55% perfusion to the right lung and 45% perfusion to the left lung. As soon as we stop ventilation of one lung, then what happens? Hypoxic pulmonary vasoconstriction occurs. So because of this, then there is diversion of blood flow to the ventilated lung. In spite of hypoxic pulmonary vasoconstriction and ventilation of the ventilated lung, there is still some amount of blood which is flowing to the lung which is not ventilated, that is to the operated lung. So this amounts to the shunt fraction. Usually during one lung ventilation, this shunt fraction will be 20%. So PEEP is 5 centimeters of water we have to keep. Now coming to hypoxic pulmonary vasoconstriction. So what is actually this hypoxic pulmonary vasoconstriction? So in systemic circulation, what happens whenever there is tissue hypoxia, there is vasodilatation occurs, so that there is more blood supply to the tissues and there is increased oxygen delivery to the tissues. But what happens in case of pulmonary circulation? In pulmonary circulation, whenever there is hypoventilation or there is decreased alveolar PO2, then vasoconstriction occurs there. So this is called as hypoxic pulmonary vasoconstriction, and it is a protective phenomenon, so that blood is diverted to better ventilated lungs and there is increase in oxygenation and also ventilation. Now we shall see what are the factors which affect hypoxic pulmonary vasoconstriction. So you can see the factors which inhibit HPV are, that is the factors where there is vasodilatation, that is in case of sepsis, cirrhosis of liver, and these inhalation agents. Among these inhalation agents, halothane, it has got maximum effect, inhibition effect on HPV. And all our newer inhalation agents like isoflurane, desflurane, and sevoflurane, they minimally inhibit hypoxic pulmonary vasoconstriction. And any this alkalosis, respiratory or metabolic alkalosis, they inhibit HPV, and this hemodilution, hypothermia, all this, and Trendelenburg position all inhibit HPV. These vasodilators like NTG, SNP also inhibit HPV. Now for the factors which promote HPV are, that is this acidosis, whether it is respiratory or metabolic acidosis, and drugs like dexmedetomidine and clonidine, and lung retraction. So when lung is being retracted, what happens? So the lung which is being operated or which is retracted, there the blood supply will be decreased, and so there is HPV occurs because that is not being ventilated, and is phenylephrine also facilitates HPV. So the factors which have got no effect on HPV or epidural anesthesia has got no effect, and usually these intravenous agents like fentanyl and propofol, they have got very minimal effect on the HPV. And vasopressin is one drug which has got effect only on systemic vasculature. It has got no effect on the pulmonary vasculature. Now we are doing this case of one lung ventilation. The patient is posted for pneumonectomy or lobectomy. So suddenly patient developed desaturation. So what we have to do? So if the desaturation is developed suddenly and it is very fastly progressing, then what we have to do is we have to do immediately two lung ventilation we have to do. If there is a gradual fall in saturation, gradually desaturating, then what we have to do is check if 100% oxygen is being delivered to the patient or not, and check the position of the double lumen tube with fiber optic bronchoscope. So if it is dislodged, because usually with lateral position there sometimes will be dislodgement of the double lumen tube, and we have to maintain normal cardiac output, and we have to decrease the inhalation agents to less than 1 Mach value, because they inhibit the HPV and they increase the shunt fraction and they cause desaturation. And we have to apply PEEP to the dependent lung and CPAP to the non-dependent lung, and also we have to consider two lung ventilation, intermittent two lung ventilation. In spite of doing all these maneuvers, if still patient is desaturating, then the surgeon has to clamp the pulmonary artery, okay, because that is the one which is contributing to the shunt fraction. So this is done in patients who are posted for pneumonectomy, that is clamp pulmonary artery in patients who are posted for pneumonectomy. Now coming to, can we use nitrous oxide during one lung ventilation? So the answer is no. We should not use nitrous oxide during one lung ventilation, because nitrous oxide it inhibits HPV, and the incidence of atelectasis when oxygen nitrous oxide mixture is used is more when compared to oxygen and air mixture. And also nitrous oxide, it increases the pulmonary artery pressure in patients with pulmonary hypertension. And one more thing what we have to remember here is, whenever patient is having right ventricular systolic pressure more than 35 millimeter of mercury, they are very high risk patients for thoracotomies and one lung ventilation. Now, fluid management during lung resection surgery. because once the patient undergoes this lobectomy or pneumonectomy, what happens then? The normal lung, it receives 100% of the cardiac output. So because of this, there is more this chances of getting pulmonary edema in those patients, because there is increased hydrostatic pressure will be there. So we have to go for a restrictive type of fluid therapy in patients who are going lung resection surgery. The third space law should not be taken into consideration, and patient should be kept NBM for only 2 to 4 hours, that is just before surgery. Till 2 to 4 hours before surgery, patient can have clear liquids, and we should not take this NBM for hours, or in that is 4 night fasting fluid should not be taken for calculation. Okay, and total positive balance, it should not exceed 20 ml per kg, and urine output more than 0.5 ml per kg per hour is usually not necessary. So 0.5 is enough. 0.5 ml per kg per hour is enough in patients who are undergoing lung resection surgery. Now coming to, after the surgeon does this pneumonectomy or lobectomy, so the bronchial stump will be there. So this bronchial stump, we have to check for any leaks are there or not. So the surgeon puts a saline into the thorax, and we have to keep this APL valve to 30 centimeters, and we have to give a sustained positive pressure to the airway, so that, and we have to check for any airway leaks are present or not. In patients who are posted for only lobectomy, here the remaining part of the lung, we have to they have to be expanded fully manually under direct vision, because because otherwise it will be very difficult for a patient to inflate these collapsed areas of the lung. So that is why before complete closure of the chest, the remaining part of the lung, it has to be expanded manually under direct vision. Now coming to postoperative management. Postoperative management based upon what is the preoperative FEV1 value. So if it is more than 40%, then we can extubate on the table, and if provided patient is awake, warm and comfortable. When the patient is this FEV1 is between 30 to 40%, that is predicted postoperative FEV1 is 30 to 40%, and we have to consider extubation based upon other factors like DLCO, exercise tolerance, and ventilation perfusion scan. If it is less than 30%, then we have to go for staged weaning, and thoracic epidural anesthesia will also help in extubation in these patients. How do we do this pain management in these patients? Pain management here in these patients, there will be multiple sensory afferents will be there, that is the intercostal nerves and this phrenic nerve. Okay, so and also this brachial plexus, because of this shoulder, the patient will be having pain. So this is the reason why multimodal analgesia has to be given into these patients. Systemic opioids have to be given, and also non-opioids. So systemic opioids have got their own disadvantages, and even blocks like intercostal block and the thoracic epidural is very useful in these patients. Thoracic epidural and also serratus anterior plane block or erector spinae block, it also helps in very good analgesia in these patients. Okay. Thank you.